Today's topic is liver. So this is the largest gland in our body, having both exocrine and endocrine components. It is taking maximum part of the right side of the abdomen, occupying the right hypochondrium, epigastrium, and some part of the left hypochondrium. The upper surface is at the level of the G-fisternal joint, whereas the lower limit is at the level of L1 or at the transpyroid plane. It is red-brown in color, wedge-shaped, and it is looking like a four-sided pyramid. You can see the superior surface, anterior surface, posterior surface, inferior surface. This is apex, this right surface is the base. So in that way, you can imagine this is like a four-sided pyramid shape. Regarding the weight for the adult male, on an average 1.5 to 2 kilo. For adult females, 1 kilo to 1.5 kilo. But in the newborn, it is almost occupying 2/5 of the abdomen. The size is much bigger comparatively because of the hemopoietic function. It is almost 1/18th of the body weight, whereas in the adults, it is 1/40th of the body weight. It's around about 150 gram in the newborn. Now we are going to tell about the external features, where we will discuss about the huge diaphragmatic surface and the visceral surface. Diaphragmatic surface can be divided into superior surface, anterior surface, the right side, and the bare area of the liver. You can see the bare area very carefully. You can see a line demarcation. So this is rough area, this is smooth, this is peritoneal covered. But here there is no peritoneum, this is the marking. So this is the superior layer of the coronary ligament. It's attached here from liver to the diaphragm, and this is the inferior layer of the coronary ligament. It's just between the visceral surface and the diaphragmatic surface. Laterally, it is joining with the right triangular ligament, and here the left triangular ligament. Anteriorly, we are getting the attachment of the, so this is the falciform ligament, and here posteriorly we are getting the fissure for the ligamentum venosum. So this is the groove for the IVC. So how you hold the liver anatomically, for that you have to put this forceps. See, I am putting this forceps through the IVC. IVC is embedded in this groove for the IVC in the left side. So this is the left side, this is right side. So left side of this bare area. Okay, so if I am putting this forceps, so this should be vertically placed. So this is the anatomical position of the liver. Or in the exam, what you can do, you just put your finger and hold it like this way. So it should be vertical. So then it is the anatomical position of the liver. Now coming to the visceral surface. Visceral surface is bounded here by the sharp inferior border, and here the inferior layer of the coronary ligament. So this is the visceral surface, where most of the visceral surface is covered by the peritoneum, except the fossa for the gallbladder. You can see the gallbladder here, and you can see the structures. This is the porta hepatis. Three main structures are there: portal vein, hepatic artery, and bile duct. We'll discuss afterwards. And this is the fissure for ligamentum teres. So fissure for the ligamentum teres, fossa for the gallbladder, and the porta hepatis. These are the important structures in the visceral surface, whereas in the diaphragmatic surface, the important structures are the falciform ligament, see, the bare area, the groove for the IVC, and the fissure for the ligamentum venosum, where in the embryonic stage, the portal vein directly draining into the IVC. Okay. And now coming to the inferior border. If you see this, it is actually separating the diaphragmatic surface and the visceral surface. It is extending laterally and separating the right lateral surface to the inferior surface, and it is going medially and separating the anterior surface to the inferior surface. Two important features there. one is the notch for the ligamentum teres, and one notch here is a cystic notch, round about 5 centimeter from the median plane, which is corresponding with the gallbladder, fossa for the gallbladder. You see the cystic notch. So this is all about the inferior border. Now I will discuss about the different lobes of the liver. Lobes of the liver can be categorized as anatomical lobes and physiological lobes. If we see on the diaphragmatic surface, we'll see the liver is divided into left lobe and right lobe by this falciform ligament. So if it is a pyramid shaped, the base is formed by the right lobe. It is almost 6 times bigger than the left lobe. So this is the anatomical lobe if we see the liver from the diaphragmatic surface. And if we see the liver from visceral surface, liver can be divided into 4 lobes. So if we see here the fossa and the fissures, then easily we will understand these 4 lobes. So this is one fissure, the fissure for the ligamentum venosum. This is fissure for the ligamentum teres. This is the fossa for the gallbladder. In here we are getting so this is the groove for the IVC, and this is the porta hepatis. So if we are imagining a H where one side of the H is formed by this 2 fissure and other side of the H is formed by this groove for the IVC and the fossa for the gallbladder, and the middle line of the H is this porta hepatis. So the left lobe is left to the fissure for the ligamentum teres and ligamentum venosum. Right lobe is right side of this fossa for the gallbladder and the groove for the IVC. And this part, in between this fissure for the ligamentum teres and the fossa for the gallbladder, below the porta hepatis, that is the quadrate lobe, and this is the caudate lobe, which is in between the fissure for the ligamentum venosum and this groove for the IVC above the porta hepatis. So in this way, these are the anatomical lobes which we can see in the visceral surface: left lobe, right lobe, caudate lobe and quadrate lobe. Now we'll discuss about the physiological lobes. Physiological lobes are formed due to the intrahepatic distribution of the hepatic artery, portal vein and the bile duct. Physiologically, liver is divided in a sagittal plane, which is also called canthali plane, and when it is taking posterior, it is corresponding with the fossa for the gallbladder and the groove for the IVC. So if I am dividing like this way, the cystic notch, so that is the actually physiological division of this liver. It is making the physiological right lobe and physiological left lobe. So they are almost equal. Again, the right physiological lobe is divided anterior and the posterior part, and this left lobe is divided into medial and the lateral part. Again, this anterior and the posterior part are divided into superior and inferior. In the same way, this medial and the lateral part also divided into superior and inferior. In that way, the 8 hepatic segments are there in the true lobes. All the lobes, they have the primary branches of hepatic artery, portal vein and hepatic duct. Regarding peritoneal relations, maximum part of the liver is covered by the peritoneum except the bare area of the liver, already discussed. Again, I am showing clearly, you can see the demarcation where the superior layer of the coronary ligament is attached, inferior layer. So this is the bare area. Here we will get the right triangular ligament, left triangular ligament. So this is one area, and there is fossa for the gallbladder, groove for the IVC, fissure for the ligamentum venosum and the porta hepatis. So these areas are devoid of peritoneum. Now we will discuss detail about the ligaments of the liver. ligaments of the liver can be divided into true and the false ligaments. False ligaments are actually the peritoneal folds, and true ligaments are the remnants of the embryonic structures. In the false ligament, we will see first the falciform ligament, then the coronoid ligament, right triangular ligament, left triangular ligament, and from this porta hepatis we get the lesser omentum. So first is the falciform ligament, that is the peritoneal fold which is attached to the lower surface of the diaphragm, the liver, and this part is attached to the anterior-abdominal wall up to the umbilicus. Now coming to the coronoid ligaments. So earlier you have seen this bare area, clearly you can see the demarcation. So that is the attachment of the upper layer of the coronoid ligament which is attaching liver to the diaphragm, and this lower layer of the coronoid ligament which is attached to the upper part of the kidney. So now coming to the right triangular ligament. So you can see this is the right side, left side, you can see like this way also. So this is the bare area where superior layer of the coronoid ligament, inferior layer of the coronoid ligament. So actually at this corner, a small peritoneal fold which is connecting the right lateral surface of the liver to the diaphragm and is enclosing the right corner of the bare area. Okay. So now the left triangular ligament. So this is right side, left side. This is another very small fold of peritoneum which is attaching the upper medial surface of the liver to the diaphragm. So that is the left triangular ligament, right triangular ligament, superior layer of the coronoid ligament, inferior layer of the coronoid ligament to the kidney, the falciform ligament, and last I will discuss about the lesser omentum. So that is the peritoneal fold which is attached to the lesser curvature and the proximal part of the duodenum to the liver. It is a J-shaped. It will show you if you see the stomach. You can see this is J-shaped. So here the peritoneal fold is going up. So it will also looking like J-shaped. So this part is attached to the fissure for the ligamentum venosum, and this part is attached to the porta hepatis. Now you compare this is the right side, left side. So see this. So can you see this fissure for the ligamentum venosum, and it is coming like this way. So J-shaped. It is taking J-shaped, the fissure for the ligamentum venosum up to the porta hepatis. Okay. Now coming to the true ligaments. True ligaments are actually the remnants of the fetal structures. Here true ligaments are, one is ligamentum teres hepatis and ligamentum venosum. So ligamentum teres hepatis, it is a remnant of the obliterated left umbilical vein, and it extends from the umbilicus to the left branch of the portal vein. Whereas here the fissure for the ligamentum venosum, that is a remnant of the obliterated ductus venosus, which in fetal life connects the left branch of the portal vein with the IV site. It is bypassing the liver till the portal circulation is fully developed and the liver starts working. So this is all about the ligaments of the liver. Now coming to the relations. So we have already seen the diaphragmatic surface, visceral surface, inferior border, falciform ligament, right lateral surface. So superiorly it is related with the diaphragm, lung and pleura. Anteriorly it is related with the xiphoid process and the anterior abdominal wall. The most important thing is the lateral wall, where it is extending in between the 7th to the 11th rib. As the upper 1/3, it is related with the lung as well as both pleura. Middle 1/3 is related with the costodiaphragmatic recess, which is extending up to the 10th rib. So in that place, we are not getting lung, we will get only the pleura. So that is a safe place for the liver biopsy. And we are coming to the lower 1/3, where neither we are getting lung nor pleura. So that's why if any time is required to take the biopsy material for the liver, they should go in between the 9th and the 10th intercostal space, where there will be no chance of lung injury. So now coming to the relation to the posterior surface of the liver. In the posterior surface, the structures what we already got, one is the bare area, groove for the IVC, part of this caudate lobe, and the posterior surface of the left lobe. The left part of the bare area, we are getting IVC, where the hepatic veins are drained, and is also related to the diaphragm and the right-sided suprarenal gland. And at the level of caudate lobe, we are getting the superior recess of the lesser sac. So these are the structures related to the posterior surface of the liver. IVC, where the hepatic veins are drained, the superior recess of the lesser sac, suprarenal gland, and the diaphragm. And this posterior surface of the esophagus, which is related with the abdominal part of the esophagus, you can imagine. So if the stomach is like this way, so here is the abdominal part of the esophagus and little bit of the fundus. So this posterior surface of the left lobe is related with the abdominal part of the esophagus and the fundus of the stomach. So this is all about the relation of the diaphragmatic surface. Now coming to the relation of the visceral surface. So you can see this. So this is right side, left side. So this is left lobe, this is right lobe. So this part, if you imagine just now, I was showing, if we keep it like this way, because we got the esophageal impression and the impression for the fundus, got it here in the posterior surface, in the left lobe. Now in the inferior surface or in the visceral surface, this part with the gastric impression, where the anterosuperior surface of the stomach will be there. And little lateral to this, so this is the fissure for ligamentum venosum. So here the lesser omentum is coming. So this elevation is called the omental tuberosity or tuber omental. Now we know this is the quadrate lobe. So here, as the stomach is there, so this part will be the pyloric part, which is like the stomach is coming like this way. Okay. So here we will get the pyloric impression. This is the fossa for the gallbladder. So gallbladder will be there. Now coming to this inferior surface of the right lobe, the lower part, the colic flexion will be there. So colic impression. And we have seen this is the bare area. Just below the bare area, this part is for the right-sided kidney. It's a kidney, renal impression. And last, this very small area, first in the second part of the duodenum, just anterolateral to the fossa for the gallbladder. So these are the relations of the visceral surface. Now, last I will discuss a little bit about the porta hepatis. You see this, there is a gateway of the liver. So porta hepatis, actually horizontal fissure, you see like this way. So, see, it is coming like this, so it is horizontal. Okay, and so if we see like this way, this is the most posterior, you can see the vein here. So then the artery and here will be the duct. So in that way they are related, posterior to anterior, vein, artery and duct. So this is all about the liver.